Welcome to the Boston Structural Heart course case series section. In this specific section, a clinical topic will be discussed in a case-based fashion with a problem-based learning approach amongst a panel of experts. In this particular module, Dr. Aidan Sharkey will be presenting a brief overview of the presentation and intraoperative management of 4 cases of ischemic mitral regurgitation. Then we will be discussing the spectrum of presentations of ischemic mitral regurgitation and the nuances of patient-specific intraoperative decision-making. There will be 4 cases, with each followed by a case-specific discussion between myself, Dr. Andrew Maslow, and Aidan Sharkey. Enjoy.
Hello everyone, my name is Aidan Sharkey. I'm an attending at Beth Israel Deaconess Medical Center in Boston. And today we're going to be discussing ischemic mitral regurgitation, and we're going to be doing this by having a case-based discussion. I have no conflicts or disclosures related to this topic. So my plan today is to discuss ischemic mitral regurgitation, and we're going to give a brief background on this topic before going through 4 unique cases where I will discuss the rationale and decision-making process behind each case. So when we think about ischemic mitral regurgitation, it is important to remember that this is not a leaflet problem, but instead an apparatus problem. Indeed, the valve leaflets can be thought of as innocent bystanders, and regurgitation is primarily due to papillary muscle displacement, leaflet tethering, reduced closing forces, and annular dilatation. There are many controversies when it comes to ischemic mitral regurgitation, and still significant research needs to be done in this area. Some of the controversies in this area include who should have an intervention, when should this intervention be done, what intervention should be done, and does this intervention have any survival benefit for these patients? The American College of Cardiology and American Heart Association have guidelines trying to answer some of these questions and state that intervention should be considered in patients undergoing coronary revascularization with moderate to severe mitral regurgitation. Then it comes to the question as to what intervention should be undertaken at the time of surgery. Should patients undergo mitral valve repair, or should patients undergo mitral valve replacement? This is a complex and important consideration for patients, and recent randomized controlled trials have attempted to answer this specific question. In this randomized controlled trial that looked at repair versus replacement, the authors found no significant difference in left ventricular reverse remodeling or survival benefit between patients who underwent mitral valve repair and those who underwent mitral valve replacement. In the 2-year follow-up to this study, the authors found that mitral regurgitation recurred more frequently in the repair group, resulting in more heart failure-related adverse events and cardiovascular admissions. However, the authors did note that on subgroup analysis that patients in the repair group who did not have recurrent mitral regurgitation had significant reverse remodeling and a better quality of life. So maybe the real question is, how can we carefully select patients who will benefit from mitral valve repair surgery? This is where we as cardiac anesthesiologists play an important role in the decision-making process. Transesophageal echocardiography, and more specifically, 3-dimensional transesophageal echocardiography, plays an integral role in guiding therapy and in the decision-making process. The value of 3D echocardiography is that it has the ability to assist us in navigating through complex decision-making with regards to mitral valve interventions and providing a roadmap for mitral valve repair. In our department, we perform a lot of mitral valve interventions, and in order to standardize our approach and be consistent with the information we deliver to our surgeons, we try to follow an algorithmic approach to determining if a mitral valve is suitable for repair or if a replacement is a better option for this patient. We have recently published our approach, and this approach is not meant to replace well-established guidelines that already exist on how to examine the mitral valve, but merely to highlight how we approach a mitral valve for suitability of repair. This is our algorithm that we utilize, and I'll be referencing this algorithm throughout the remainder of our talk when we begin to discuss some cases related to ischemic mitral regurgitation. So moving on to our case-based discussion, when we encounter ischemic mitral regurgitation in the operating room, we generally encounter it either emergently, acutely, or as an incidental encounter. Our first case that we're going to go through is a 74-year-old male who had a ST elevated MI. He presented hemodynamically unstable with an inferior MI and had an intra-aortic balloon pump in situ for hemodynamic support. He was brought to the operating room for an emergency coronary artery bypass surgery. On initial TE examination of this patient, we can see that there was a rupture of the posterior medial papillary muscle, as seen in these views. And more views, we can clearly see that the ruptured papillary muscle, and there's also a flail anterior leaflet as a consequence of this ruptured papillary muscle. Looking at this valve on 3D imaging, we can see that there's a flail leaflet in the left atrium. And with the color flow Doppler applied on our three-dimensional image, we can see a posteriorly directed jet of severe mitral regurgitation. So clearly this patient needs a mitral valve intervention. And looking at how we first approach a mitral valve, it is our first step to exclude immediate contraindications to repair. And contraindications that we consider that preclude a potential repair include patients with infective endocarditis, patients with significant mitral stenosis, patients with significant mitral annular calcification, and also emergent surgery with ischemic papillary muscle rupture, where definitive operation and minimal bypass time is of the essence. Consequently, in this situation for our patient, we proceeded with a coronary artery bypass surgery with a mitral valve replacement. Obviously, a valve sparing procedure could not be done, so the damaged papillary muscle and leaflet were resected, as we can see in the specimen in this image.
Now, all right, Aidan, thank you very much for this case presentation. So, seems like this case presented with acute hemodynamic instability, and the MR was not known. Is that what usually happens, Andy, that MR is not known?
For an acute inferior wall MI that's hemodynamically unstable, my feeling is that, my understanding, it's either associated RV failure or ischemic mitral regurgitation that gets this unstable that requires intra-aortic balloon pump. Anterior wall MIs are usually depressed EFs, but they don't have as much mitral regurgitation. But by the EKG, this was stated to be an inferior wall MI, so I'm a little disappointed that it doesn't seem like anybody put a stethoscope on the chest and recorded an exam. But either way, the hemodynamic instability, the balloon pump is the right therapy. So it doesn't seem that anything was delayed. But I would suspect that this was there before. It wasn't.
I think Aidan chose to do esophageal stethoscope on the patient.
Yes.
So what do you think, Aidan?
Yeah, I mean, I totally agree with Andy. And especially both, that we could be doing more stethoscope work, but also, Andy, what do you think in this day and age where we have the availability of pocket probes to plug into your iPhone, plug into your iPad? Maybe could we have put a transthoracic probe in this patient and seen it then?
Yeah, so take your pick. If you're facile and you've got the portable ultrasound, actually, is my bag over there?
You want to show off your portable ultrasound, Andy?
For example,
there you go.
If you got a portable ultrasound, you can hook it up to your phone and definitely get some images.
Yeah.
And I think that's great. And it's so our cath lab where we are, we, believe it or not, do not have a dedicated echo machine up there. We should. But that would make things like this so much easier. So it depends really on how facile you are with a transthoracic probe. If you've done, a lot of them, I think the criteria is 300-400 and then 50 a year performed. But a stethoscope is very quick and easy. And this kind of hemodynamic instability, I can't imagine somebody wouldn't have picked it up with a stethoscope also.
So let's have, but getting to the point over here, Andy, is the fact that, do you think a papillary muscle rupture is considered an absolute contraindication to repair, or are there any, it better, are there any incidents of reports or people repairing these valves also?
Well, I mean, I think, is it an absolute contraindication? No. However, I think you need to take the broader picture into consideration. The patient's unstable. The patient is 74. And I think the most prudent thing to do in this situation is to do a definitive procedure where, you don't have to worry about potentially going back on bypass for a failed repair, for SAM, or anything that might add to the bypass time. Or re-rupture after that. So is a repair possible? Yes. Is it the most best thing for this patient? I don't think so.
What do you think, Andy?
Yeah, well, first of all, it's an anterior leaflet flail. Is that correct?
Yes, sounds like yes.
Yeah, so right away the repair falls into the slightly more complicated category anyways. Quickly, yeah, this valve would be replaced at most places. If you're really facile with repairs and are ready to put a bunch of cordia in to repair an anterior leaflet, then I think you can do it, and you can have a pretty decent outcome. Anterior leaflet repairs have a simple anterior leaflet repair have about a 30% re-op rate, right, or recurrence of MR within 5 to 10 years. A prosthetic valve, and this guy a bioprosthetic valve can get him 15 years or more. So.
And where would you put the cordia, given it the pap muscle rupture? I mean, where do we attach the cordia to?
Right. So you'd have to start digging a fair bit deeper into the ventricle, into potentially infarcted tissue. So, like I said, I think if you're going to repair this valve, I'm hoping that you've done at least 50 of these before. If you haven't, it's arguably a lot safer.
So I take it that a ruptured papillary muscle is almost a certainty a replacement.
Well, so I guess it depends on which leaflets flail, right? If you don't have to put a lot of cordia in, and all you're going to do is resect and tuck, and again, you're facile at repairing valves, and it's a posterior leaflet issue, and you can just resect it and jump off after that, maybe. But even that, sick patient, balloon pump, it's probably easier to do what's quickest and most reliable.
So I take it, Andy, that you also think that patients who have inferior MIs should also be scrutinized for RV failure at the same time as you suspect papillary muscle rupture of that. All right, so we'll move on to the next case.
Moving on to case number 2. This is a case of acute ischemia in the operating room. And this is a 68-year-old male with shortness of breath and chest pain on exertion. He had a background history of known ischemic heart disease along with hypertension and hyperlipidemia. He proceeded to have a coronary angiogram to investigate his symptoms and was found to have severe 3-vessel disease. Of note, preoperative transthoracic echo demonstrated mild mitral regurgitation. He presented to the operating room to us for his coronary artery bypass surgery and underwent uneventful induction of general anesthesia. We performed a baseline transesophageal echocardiography, which showed moderate LV dysfunction with a global hypokinesis and also an akinetic apex. Examination of the mitral valve in this patient showed no more than mild mitral regurgitation, which was as advertised in this patient. Pulse wave Doppler of the left upper pulmonary vein showed mild blunting, and a vena contracta was consistent with mitral regurgitation. So our initial analysis was this was a patient with moderately depressed LV function with mild mitral regurgitation. As the surgery proceeded and the mammary was being taken down, we noticed that there was some hemodynamic changes. More specifically, the patient started to become a bit more hypertensive, tachycardic, and the PA pressures also began to rise. We decided to have another look with the transesophageal echo. When we looked with the transesophageal echo, we noticed that there was significantly worse LV dysfunction, with now almost complete akinesis of the inferior wall. We re-examined the mitral valve and noticed that the mitral regurgitation was considerably worse, with a large central jet of mitral regurgitation, as we can see in this image here. Further assessment of the mitral regurgitation showed that the regurgitation was of moderate to severe intensity, which was a big change from baseline in this patient. We also noticed that the coaptation of the mitral valve leaflets was not as good as baseline. We felt at the time this was all ischemia related, and we were not ready to go on bypass yet, so we decided to start some anti-ischemic therapy with nitroglycerin. And as we can see, when we started the nitroglycerin, we had a nice downward trend in both the systemic arterial pressures, but also the pulmonary artery pressures also. And also, after we started the anti-ischemic therapy, we saw an immediate improvement in LV contractility and also an improved coaptation of the mitral valve leaflets. We again re-examined the mitral regurgitation after initiation of our nitroglycerin, and the regurgitation had come back down to mild in nature. Looking at the regurgitation pre and post nitroglycerin, we can see a considerable improvement with moderate to severe pre-nitroglycerin infusion, and post-nitroglycerin infusion, the patient now had mild mitral regurgitation. So the question we were faced with in the operating room was, what do we do in this situation? Should we ignore the mitral regurgitation and do our originally planned procedure of CABG? Should we do a CABG and mitral valve repair? Or should we do a CABG and mitral valve replacement?
All right, Aidan, thank you very much for this case presentation. You are in quite a bit of a dilemma over here, which is an MR that is responsive to ischemic therapy, which is acute in its presentation. Andy, is something that you have encountered, obviously. What would be your approach to this mitral regurgitation? Ignore it or go for some surgical therapy for this thing?
Oh, I'd called out sick. So you never ignore it. I don't think that there's enough there to warrant doing a valve surgery here. And I say that for a couple of reasons and one assumption. One, prior to coming in, and I'm just going to assume that that transthoracic study was performed reasonably close to the surgery, maybe within 24, 48 hours.
Correct.
Or so. Because if it was done a month ago, then it's, I don't want to say useless, but not as telling. So prior to anything, he had mild mitral regurgitation. So right away, I wouldn't be planning on mitral valve surgery at that time, unless you told me prior to going to the operating room, prior to go to sleep, you did a quick transthoracic and he had, moderate plus mitral regurgitation in pre-op.
The point I'm trying to ask Andy
Yep.
is that normally general anesthesia is associated with underestimation of mitral regurgitation. If it's more than what was reported, then obviously it's very significant then.
Right. And so hence why I'm talking more about the pre-induction examination and evaluation. So in the operating room, I'm going to make the assumption that the patient has bypassable disease and you have a surgeon who performs decent bypasses. So therefore, you will also then add on to this anti-ischemic therapy by having the bypasses. So you had mild mitral regurgitation before you came in. You had post-induction mild mitral regurgitation, even though you had significant ventricular dysfunction, right? Because the ventricle was definitely had systolic dysfunction, and I know qualitatively you can't say, but it looked very stiff also. So I would actually go ahead with the bypasses. Wouldn't ignore the mitral valve regurgitation. Would certainly be part of your assessment, but I don't see anything here that means that you should replace this valve.
I meant repair also. Do you think so?
I don't see any need that you should do anything to this valve at this time.
So the reason I'm asking this thing is that fortunately this patient has high-grade proximal stenosis, which means that possibly he doesn't have microvascular disease, which means it's likely to respond to purely an anti-ischemic therapy of revascularization. But what if this patient had diabetes on top of that, poor runoff, and you'd know that the bypass is not going to be that effective as it would be in a non-diabetic?
So there's a couple of things. One, let's just add to this, because your question here is, maybe we're not seeing the mitral regurgitation that the patient may have had prior to, and maybe he's been optimized since he's been in the hospital.
Exactly.
So, and his ventricle is a bit dilated, but it's kind of stiff, and it doesn't really look like this big, globular mitral regurgitant ventricle. But if you tell me the left atrium's 6 centimeters or so, and he has pulmonary edema, congestive heart failure, that might suggest that he probably has some on and off mitral regurgitation. Maybe we're not detecting it now. I didn't hear that part of the history, so it suggests to me that his MR has been fairly well controlled up until this point. So there's no indication for a prophylactic mitral surgery for mild mitral regurgitation.
So may I ask this question, Andy, that some patient has trace MR, then becomes acutely ischemic, has moderate to severe MR. Would you not consider any indices of remodeling of the valve, like you pointed out the left atrial size, to demonstrate that while this may be an acute event, but sounds like this guy's had this MR multiple times in the past?
Yeah. But you have an acute, you had a mild MR and then ischemia. You had more than mild MR. So again, if the outlook is such that the revascularization is going to be good, then I would suspect your anti-ischemic therapy, surgery, even medicines. I mean, just because he has a bypass doesn't mean he stops all his medicines afterwards. I would think that would be quite adequate for her to control mitral regurgitation afterwards. I still don't think there anything warrant mitral valve surgery.
All right, let's keep going and see what happens in this case.
Looking at some valve geometry, we can see that this is not exactly a normal valve, and there is some degree of remodeling. However, there also did seem to be good leaflet coaptation when the patient was not ischemic, with a good anatomical or coaptation reserve. So our decision process at the time was that this was acute ischemia related, and consequently we proceeded to do a CABG surgery alone and did not actually intervene in the mitral valve, and the patient subsequently did quite well.
I take it, Andy, you're very happy with the outcome because that's what you were touting over here, right?
It's a balance, right? You do based on your experience, you base on the literature, and you make the best decision. It's quite possible that you might have come off bypass and maybe something would have happened. You would have been ischemic, and then he had ischemic MR. Then what would you do at that point?
That's true.
Would you go back on bypass and do something about the valve? Would you put a balloon pump in? Would you reassess your revascularization?
My suggestion, the thought process, while I was trying to be the devil's advocate and take the contrarian position, I think that the reversibility of the MR with nitroglycerin in this acute sense suggests that if we were to restore blood supply to the myocardium in this high-grade stenosis, it would possibly, the myocardium is alive, which means, and it is ischemic. So that's why I think that would have been my approach as well.
And for those, in those previous images we examined for coaptation reserve. Is this something you would look at as well? And is this something you routinely look at, or what patients do you look at coaptation reserve in?
Right question, but I think the gentleman who actually brought up this whole concept is sitting right next to me. I'll punt this question to Dr. Maslow.
Yeah, I mean, so there's a dilemma there. Let's just say, so the normal coaptation length, or the zone of coaptation, ideally is at least 5 millimeters. Even more, right? I think in the early literature, it was quoted about 8 millimeters, and I think since then we're down to 4 or 5 millimeters. And if you've got leaflets that you think are only coapting by 1 millimeter, then you really have no reserve whatsoever. So at that point, you make the decision of what you think the ventricle is going to look like. After you've been revascularized, is there going to be reverse remodeling? Is the ventricle going to look quite a bit better or not? There's nothing in the guidelines, though, that regardless of what you see of the valve, if there's mild mitral regurgitation, there's no indication for performing a mitral surgery.
Perfect.
Yeah, and I think this goes into the concept of just because a valve is non-regurgitant does not necessarily imply that a valve is normal.
Perfect. All right, we go on to the next case.
Moving on to our next case, our third case. This is a 72-year-old female who was found to have severe 3-vessel coronary artery disease on investigation for increasing shortness of breath and chest tightness. It was also noted at the time that she had moderate to severe mitral regurgitation on her preoperative transthoracic echo. On examination of the mitral valve, we can clearly see that there is significant dysfunction with a large central jet of mitral regurgitation. 3D imaging of this valve again confirmed our findings of significant mitral regurgitation with a large central jet. So looking at our decision-making algorithm, we can see that there is no immediate contraindications to repair in this patient, and we have clearly identified the presence of dysfunction. Our next step is to quantify the degree of dysfunction, and our primary method is the vena contracta method that we use. Despite many potential pitfalls with this method, we find it a very quick, reproducible, and good method to distinguish mild and severe regurgitation. In patients with moderate mitral regurgitation, this method should be used with caution, as it has the propensity to underestimate the degree of regurgitation, and so this method should be used along with other methods to quantify the degree of dysfunction. In our patient, we graded the regurgitation as severe based on a vena contracta of greater than 0.7 centimeters and also the presence of flow reversal in the left upper pulmonary vein, as we can see in these images here. So now that we have quantified the degree of dysfunction, the next step we follow in the decision-making algorithm is to identify the mechanism of dysfunction. And to do this, we follow Carpentier's classification. In this patient, we can clearly see leaflet tethering with an annulus that is not dilated. So in this patient, we classified the dysfunction as a type 3B dysfunction. Next, in our decision-making algorithm, we try to establish the pathophysiology of dysfunction. And in this instance, given this patient's history and known ischemic heart disease, this is ischemia related. So then our next step is to proceed with quantification of valve geometry and also to identify indices of mitral valve apparatus remodeling. When we quantify mitral valve geometry, there are simple to use artificial intelligence softwares available, such as is available on Siemens or Philips or GE machines. And these give us an abundance of information, such as is highlighted in this image here. We can also perform basic measurements manually, such as tension height, tension area. We can look at P3 leaflet retraction angle, along with some geometric indices that predict the occurrence of SAM, post-mitral valve repair, such as the AL-PL ratio, the C-sep distance, and the mitral aortic angle. Now that we have performed some geometric measurements of the valve, it is important to measure all these geometric indices, as these will play a role in the final decision as to whether we should repair or replace this mitral valve. In patients who have predictors of repair failure, such as dilated ventricles, significant leaflet retraction as evidenced by increased tension height, tension area, or P3 leaflet retraction greater than 29 degrees, then these patients proceed to mitral valve replacement as opposed to repair. Looking back at our patient, we can clearly see there is evidence of significant remodeling, as evidenced by the increased tension height, tension area, and also the P3 leaflet angle, which was measured at 59 degrees in this patient. Also, very importantly in this patient, there was evidence of a basal aneurysm that is highly associated with repair failure. So given all the evidence we've collected on this patient, our decision for this patient was to proceed with a CABG and mitral valve replacement. And so this surgery was done, and the patient did quite well in the post-operative period.
So, Aidan, thank you very much for this case. And I think Dr. Maslow is already geared up for a lot of discussion points here.
It's going to be 15, 20 minutes.
So here's, Maz, I want to ask you one simple, straightforward question. Do you think these indices of remodeling are good for papers and presentations, or do people really do them in real life also?
So, do people do all of them, I think is the question. I think as things become more automated, I think probably it'd be easier to do all of them. If you said, hey, Andy, what do you do in your practice? I would look at this valve, and the first thing I would measure would be a tenting height. One question is, where do you measure the tenting height from? Forward-chamber view, long-axis view. But if that tenting height in both views was well more than a centimeter, then right away I'd say that this, the valve has been remodeled and it's been chronic like this for quite some time. So your next question is, does it make a difference? right? And I do think that the very tethered, very tented, leaflet that's either from ventricular remodeling, papillary muscle dysfunction, chronic, or whatever, a simple annuloplasty ring for those valves has about a 30 to 40% recurrence of moderate plus mitral regurgitation within 6 months, not even within a year. So I think recognizing the mechanism of the MR, the chronicity, the remodeling, definitely predicts how well a simple annuloplasty is going to perform.
I have two comments here before I ask Aidan this question. Comment number one, and not to mention the place, but I was a visiting professor at a hospital where the cardiac surgeon had first the sonographer come and make some weird measurements of the mitral valve and then tell the anesthesiologist, go play with your echo probe. I know what I need to know now to make a decision. So secondly is, while you asked the question which said, where do you measure the tenting height, mid-esophageal four-chamber, mid-esophageal fold, mid-esophageal long axis? I know Aidan is working on it, but when we have 3D, why don't we measure the tenting volume, which represents the topography of the hole, as opposed to a section? Aidan, are you working on something like this?
Yeah. I mean, this is it's a relatively easy concept to do with the advent of 3D echo. So, using a tenting volume as opposed to just a single tomography area maybe gives a broader or a better, fuller picture of the 3D nature of the valve.
And the other thing, Andy, was that after this, the New England Journal of Medicine article came up. We were also involved in that study with the University of Pennsylvania and Groningen, where we found that the tenting of the P3 scallop more than 29 degrees represents a reversible remodeling. Do you think this should be something that can be used to discriminate patients who will recur and who will not recur routinely in a clinically feasible fashion?
Yeah, I think anybody who's severely remodeled like this is likely to recur. Now, 100% no, but 40% yes. And now you present here a 76-year-old woman,
Correct.
And who you probably don't want to bring back to the operating room again. So, to me, looking at these values and the bigger picture, it seems like a replacement would be certainly more a short therapy.
So another question on this one. Like we used to have with moderate aortic stenosis, an entire discussion point of whether to leave it alone or to do something as a concomitant surgery when you encounter it incidentally during a CABG operation, right? And the availability of TAVR has literally changed the landscape, and you're not afraid to make a somewhat a questionable decision because this TAVR is always available. Do you think the similar situation or similar thing can be applied to availability of mitral clip in these patients, and saying, geez, let's do a CABG and see if it helps. If it doesn't, we can always go back and do a mitral clip. What do you think?
So yes, perhaps more so in valves that are more amenable with a higher success rate and greater longevity with a clip. I think the last data for mitral clips for functional mitral regurgitation, I was a little bit surprised, but maybe not surprisingly, 30-40% moderate plus mitral regurgitation 6 months out. So, it's one thing if this lady had mild moderate mitral regurgitation and you're a little bit suspect and you say we're not going to do anything now and if we need to we can come later. But she's got a lot of mitral regurgitation. So your decision is probably to do something now. She already has a very abnormal inferior lateral posterior wall that doesn't look like it's going to get quite a bit better. And your measurements definitely suggested severe mitral regurgitation. So to leave the operating room with severe mitral regurgitation, or even moderate plus mitral regurgitation in this patient, I think would be the wrong thing.
No, I'm not disagreeing with you on doing something for this mitral valve. The question I'm trying to get to is that the only reason mitral regurgitation has such horrible post-operative results that we oversubscribe this operation to people who may not be amenable to mitral valve repair, who are remodeled to the point. And I personally think that with the somewhat of bias being part of that study, is that the retraction of the posteromedial part of the mitral valve, the remodeling on the posteromedial mitral valve, suggests that this is not a salvageable situation with the repair. What is your idea on this?
Yeah, first of all, it wasn't just posterior medial, right? It looked like it was fairly wide, the jet, and so let's just say you wanted to be creative and you wanted to go in and you put a full ring annuloplasty and just close up the entire P3A3 area, thinking that that's going to take care of it, you're still left with the larger problem. And then what you didn't do is you didn't calculate a valve area to see if actually repair is something to do. Now what's interesting in these kinds of patients is your first thought, well, of course the mitral valve area is going to be just fine because it's not rheumatic disease or anything like that. And there's actually a lot of diastolic restriction of the leaflets. These valve areas might not be 6-7 centimeters squared like some of the flail leaflets might be, and some of the more mobile leaflets. You might be fairly unhappy to see that your valve area might only be about 3.5 to start. So between that and the unknowns about how your repair is going to be post and then 6 months down the line, I don't see this as being something to repair now, and I certainly don't see it something to clip at any time later. Now you might say, well, let's just put an annuloplasty ring in now, and we can always come back and do a valve and ring, percutaneous, or even a mitral clip after that. And I guess it depends on how big the annuloplasty is and how amenable everything is to do a percutaneous, valve and ring case. And the valve and ring case depends on what ring you want put in. Is it a circular ring? Are you going to have paravalvular leaks after you put it in? There seems to be a lot of questions that are unknowns with this in the future. It would just seem a lot easier just to replace the valve now.
It's just a lot easier to replace the valve. So you do not let the availability of alternative therapies impact your decision now for function or ischemic MR in the room.
I think you absolutely consider all of them, realizing that each procedure you do is another procedure. And even if you, like I said, if you're going to put a ring in now, what kind of ring are you going to put in? What kind of ring are you going to put in that's going to make it amenable to a percutaneous therapy later on? What do the leaflets look like now? Is that something that's amenable to a percutaneous therapy later on? And I don't think you would put a partial ring in this patient anyways, right? So, but if you put a partial ring in some of these patients, and then you're thinking, well, I'm going to do a percutaneous valve and ring later, you're either left with a big anterior portion that's open and perhaps distortable.
Unsupported, yes.
And if the percutaneous valve doesn't fit beautifully into the ring, then you've got multiple paravalvular leaks. So no, I would absolutely consider the option to repair it, especially since I'm sure the surgeon would go in there and look at the leaflets and think to themselves, wow, you want me to get rid of these nice normal looking leaflets? And the answer is yes. Given all the other considerations and the likelihood of recurrence.
So the age-old adage that replacement is kind of a defeat is not the point. It sometimes is a victory. You just defer to you make a definitive decision at that time.
Yeah.
All right.
And I think it's important as well for us. I mean, we can all be in the operating room, do a mitral valve repair, and the repair looks good initially. Everyone gives themselves a high five at the end of the procedure. However, as Andy pointed out, it's the 6 months, 12 months, 24 months down the line where you're going to see the morbidity, and that's where we need to be thinking of. And I think the best long-term solution in this patient, given all the indices, is a replacement.
And that's exactly what you did, and let's move on to the next case.
Finally, our last case is a case where we had a 62-year-old male patient who was having unstable angina found to have 3-vessel coronary artery disease as seen on angio. Of note, a preoperative transthoracic echo was done, which showed moderate to severe mitral regurgitation. He presented to the operating room for coronary artery bypass surgery, and after an uneventful induction of anesthesia, we performed our transesophageal echo examination of the mitral valve. And our assessment of the mitral regurgitation was that it was mild to moderate in nature. Given this patient had documented moderate to severe mitral regurgitation in the preoperative TTE, we decided to augment his physiology with an increase in pre and afterload. And with this, we noticed a definite increase in the severity of mitral regurgitation. This concept of matching awake state hemodynamics when assessing the degree of mitral regurgitation has been shown to be more accurately assess the degree of mitral regurgitation with patients under general anesthesia, with the caveat of sometimes overestimating the severity, so it must be used with some degree of caution. Further examination using three-dimensional imaging of this patient did not reveal any structural abnormalities of the leaflets. However, there was some leaflet tethering seen when the valve is viewed from the left ventricular aspect. When we add a color flow Doppler to our three-dimensional imaging, we can see that there is a significant jet of central mitral regurgitation. And using some of the new rendering software, such as the glass view, as we can see here, we can really appreciate the broad base of the mitral regurgitation jet. So again, going through our decision-making algorithm, we can see that there is no immediate contraindications to repair in this patient. And we have clearly identified the presence of dysfunction. Our next step is again to quantify the degree of dysfunction. And as I stated previously, we routinely use the vena contracta method. While this method is good, as I previously said, in that it is quick, easy, reproducible, being relatively load independent, we must also appreciate its deficiencies, especially in patients with ischemic mitral regurgitation, where the effective regurgitant orifice area is non-circular in nature. Consequently, using the vena contracta in patients such as this will often underestimate the degree of mitral regurgitation, as we can see in our case, where we measured the 2D vena contracta to be 0.5 centimeters, which would put this patient in the moderate range of mitral regurgitation. In cases like this, where there are some discrepancies between measurements, we will routinely move on to more accurate measurements, such as using 3D vena contracta. And this is a more accurate measurement in patients with ischemic mitral regurgitation, as the jet is more elliptical and non-circular in nature. And we can see in our patient's instance, the 3D vena contracta was measured at 0.41 centimeters squared, which clearly puts this patient in the severe range and most definitely warrants intervention for this valve. So again, looking at our decision-making algorithm, our next step would be to identify the mechanism of dysfunction. And again, we do this according to Carpentier's classification. With our patient, we can see that there was no excessive leaflet motion. The annulus was not dilated. However, there was some evidence of leaflet tethering. So we classified this again as a type 3B dysfunction. And in terms of establishing the pathophysiology of dysfunction in this patient, it is ischemic in nature. So our next step is to quantify valve geometry and identify indices of mitral valve remodeling. As stated previously, we routinely measure tenting height, tenting area as markers of remodeling. And these two measurements can be done either in your two-dimensional views, or we typically do all our measurements using multiplanar reconstruction. The value of using multiplanar reconstruction is that you can be very precise in your measurements, and you also know exactly where you are taking your measurements from. This is especially important when you're trying to determine the P3 leaflet retraction, where multiplanar reconstruction allows you to easily confirm that it is actually the P3 scallop you are measuring, and this is something that cannot be achieved with two-dimensional echocardiography. And we can see in our patient here, we measured the P3 leaflet retraction, which we calculated as less than 29 degrees. We also routinely measure for predictors of SAM after mitral valve repair. And again, we do this using multiplanar reconstruction, where we measure the AL to PL ratio, the C-sep distance, and the mitral aortic angle. So putting all this together for our patient that we are describing, we can see that while this patient has evidence of remodeling, there are no geometric indices indicating that he is at risk of repair failure. Specifically, this patient's tenting height, tenting area, and P3 leaflet angle and LV dimension all point towards patient having a durable repair if he underwent mitral valve repair. So as a result, for this patient, we decided to perform a mitral valve repair as part of his bypass surgery, and this patient went on to do very well in the postoperative period. So, in conclusion, ischemic mitral regurgitation is a complex problem of the mitral valve apparatus. Intervention should be considered in select patients undergoing coronary artery bypass surgery. And intervention in the form of a mitral valve repair is not an operation for every patient. And indeed, we as cardiac anesthesiologists using three-dimensional echocardiography should be guiding therapy as to which patients would benefit from mitral valve repair and which patients may not benefit from mitral valve repair who would go on to have a recurrence of their mitral regurgitation. Just to finally look at some future studies in this area, and we at Beth Israel Deaconess are very interested in trying to figure out if we can somehow identify patients who might be at future risk of regurgitation, and if early intervention might be an option in these patients. Just because a valve is non-regurgitant does not automatically imply that it has normal function. And this idea plays into the concept of mitral valve coaptation reserve and the risk of mitral regurgitation. This coaptation reserve acts to sustain ischemia-related remodeling and prevent development of mitral regurgitation. And based on the available reserve, non-regurgitant mitral valves could vary in their risk of developing systolic incompetence. And potentially identifying these patients early could possibly lead to improved outcomes. And this is an area that we are actively investigating, and I think a lot of potential future research in this area. So I'd like to thank everybody, and I hope you enjoyed this case-based discussion on ischemic mitral regurgitation.
So in this case, we had a patient with mitral regurgitation, not significant indices of remodeling. You went on to do repair. Despite Andy wanting to make more points about remodeling, I'll ask a more provocative question. We talk a lot about this mitral regurgitation assessment, and people argue about PISA method and the vena contracta method and all that stuff. Don't we just, in reality, just eyeball it and take a look at it and say it's mild, moderate, or severe? What do you think? You, Andy.
If you're going to make a decision on
Be
something,
be honest.
Yeah.
It's just friends. We're amongst friends.
I'm always honest.
Okay, perfect.
Actually, do you ever hear somebody go, "Well, to be honest"? Right? When they say that, does that mean they're not being honest if they don't say that?
That's true.
So if you're going to tell the surgeon or proceduralist to do something based on what you've done, you should quantify. And I guess if it's torrential stuff, you could eyeball that and just say, oh, it's torrential, it's this. And a ruptured pap muscle, probably not much you have to quantify there. It's a ruptured pap muscle. When you come down to something like this and you're trying to decide whether to repair or replace, if you're going to tell the surgeon, oh, you should replace it, you should have definitive reasons that are reproducible. All right. Qualitative assessment, for the most mild and the most severe are probably reproducible, but anything in between isn't as reproducible. There are some qualitative things you can say, right? So if you've got flow convergence, you have at least moderate problem. Right? You're not going to have flow convergence with less than moderate. So that right away points to a problem. And you can measure the flow convergence and get a crude idea, but again, that's quantitative data. So as far as what to do with the valve, deciding how much this valve is remodeled is a great idea, especially if your hint is to repair the valve versus replace the valve. Now, sometimes the surgeons will go in and take a look for themselves and they'll get an idea. Everybody thinks a type 3B dysfunction is associated or has leaflet restriction because of chordae and pap muscle. The fact is, in the chronic case, the leaflet themselves are less compliant and are a bit stiffer. So not all leaflet restriction is due to subvalvular apparatus. So it certainly can be a non-compliant leaflet, which would not be great for repair.
Well, Andy was honest, but he still did not answer the question.
What was the question?
Do you routinely eyeball and say, this is moderate? And with your experience, tell me, how often are you wrong with your eyeballing about moderate?
We eyeball and we quantify, so we don't always just eyeball. And like I said, if you're going to try and guess moderate or more, or moderate or less, I think you're going to be right maybe 50% of the time.
If I was to have a crystal ball and say there's one thing in echocardiography that needs be the innovation for the next 10 years. That would be converting, getting the actual flow information in the images. Right now we use velocity maps as indirect surrogates for volume maps. But in all fairness, every time my bias is that we eyeball, we make a decision, and then we use quantifications that agree with our eyeball back. And then just say, okay, how often we go and say, it looks trace, and you go and say, it's moderate. Would you agree with your quantification or your eyeball situation in that?
Yeah, if I believe my quantification was done well, my quantification. And the reason why I say if I believe it was done well, there are times when you can get a nice 4-6 beat volumetric data set with color Doppler and think that you're going to go and trace the 3D effective regurgent orifice area. And what you find is as you're starting to align your planes on the multiplanar reconstruction or the multi-view thing, right? You have that option too. What you find is sometimes right at the valve, for whatever reason, maybe there's dropout. And there's almost no color. And then you say, well, should I raise my plane up a little bit? Now you're getting into a jet. So the central jets especially that start to expand. All right, so where do you actually make your measurement? Is there a color Doppler bleeding? So you really do get into that question of how accurate your color Doppler is, even when you're trying to quantify it, which means that your qualitative assessment is probably even less accurate. So we quantify everything we can, but we do realize that sometimes your color Doppler may not be perfectly accurate either.
So in our place, there's one thing to hang your hat on and one thing that decides between mild and moderate or moderate to severe, we use vena contracta. Is that what you use in your place, or do something different?
So yes, but we also, I'd say half of us capture a 3D volumetric data set and crop it down so we can measure a 3D regurgent orifice.
If there's discordance, which one do you believe?
If there's discordance, I would believe the 3D regurgent orifice area.
I would actually argue that because the more assumptions that are built into it and the more reconstruction that is built into it makes it a likelihood of some more erroneous possibility of error.
Now, can you be sure when you're measuring your 2D image or measuring on your 2D image that you're getting perfectly across the jet and in an accurate part of the jet? I mean, it's very clear that you shouldn't measure this in the bicommissural view because that will overestimate your mitral regurgitation. So you either measure it in the 4-5 chamber view or the long axis view. If you're in the long axis view, and I don't think anybody pays much attention to it, if you see any pap muscle, well, then you're obliquely across the leaflets already. All right. So if you get into either view and you say, oh, I didn't see any subvalvular apparatus, well, you're probably in the middle of the leaflets, assuming though that that's where the regurgitant jet is.
But you can do this vena contracta in everyone, and 4 to 6 beats reconstruction in patients with atrial fibrillations and arrhythmias and bovine interference is sometimes impossible. So, and most of the time, sometimes these patients have these problems. So that's why I'm a little reluctant. And also, as you realize that the grayscale information and the Doppler information are not synchronously acquired. They are acquired at different time intervals. So there's a temporal dysynchrony between the two of them. So when the leaflets are the closest, may not necessarily be the time when the jet is the widest also. So it's basically a superimposition of information or an after-the-fact reconstruction. So that's my skepticism, and your points are well taken, that same thing is applicable to 2D also. That's perfectly fine.
But as well, Feroz, I think a very important note is that there's no one method that is universally accepted as being the best, and I think it's important that your institution has a uniform, consistent way so that you're not jumping from one parameter to another parameter, so that there is some sort of uniformity in how you quantify it, whether that's, and each way has its pitfalls and advantages. Using EROA, 3D vena contracta, as you said, in patients with AFib where you have a poor temporal resolution, you may only be analysing 2 frames. So it's not very useful there. Whereas we all know the pitfalls of using 2D vena contracta.
But one thing you have stated, you don't use PISA to do anything, right?
I don't use PISA.
So that's purely for pimping your fellows and residents, so that's what it is?
I don't even bother using PISA to pimp my residents and fellows. It's actually not a horrific measure. It's just not as predictable because your flow convergence area is just not reliably circular, and it's based on a lot of geometric assumptions. Right.
Perfect. I think this quantification of mitral regurgitation could be the subject of another podcast. And let's get some controversial cases and put it out there and see how you quantify with it.
Yeah. So, but I have a different question. Okay. So the repair versus replace thing, and there's two questions I have, if you don't mind. One, why don't you want to replace a valve, other than the finite morbidity of a prosthetic valve each year, which is, depending on the patient, 1 to 2%. I get that, but why don't you want to replace the valve, acutely?
So, just to answer the question, one is purely intuitive. It's any foreign body within the body's back. That's
Sure.
number one. Number two, if with a reasonable degree of experience, and the surgeon has this thing, if we can give the patient his native tissues and specifically preserve the geometry of the ventricle by preserving the subvalvular apparatus, which is an important component, not just the leaflets. And therefore, that would be one major reasons of avoiding prosthetic material. Secondly, is preserving the geometry of the ventricle.
Good. So, in that last part, preserving the geometry, is there enough data out there that says that you can preserve the geometry with a prosthetic valve in place, and that the resultant ventricular function is similar?
So that would only be possible if you are practicing the subvalvular sparing or preserving technique. Well, again, that brings into the question, Andy, is that these are somewhat surgeon-specific techniques. People who are experienced at doing these things, who will take their time to do this kind of stuff. So the decision to replace or repair, I would say, is contextual, with the expertise of the surgical colleagues being the major determinant of what should be done. The same valve can be easily repaired with an experienced surgeon, where in other centers, it'd be a horrible repair with the patient coming back with something else.
Yeah. Now, and just getting back to these cases in particular, your 3D data, your 3D volume set prior to bypass, it didn't look like it was the biggest valve area. And I noticed that on none of the things that there was any measurement of valve area before or afterwards.
So in the presentation, no, but we do again routinely use our multiplanar reconstruction, and we will do planimeterize a valve area. And obviously, the first step of our algorithm, the first thing is you want to rule out any degree of mitral stenosis, because any mitral valve repair will cause an immediate and continued kind of reduction in your mitral valve area. So you don't want to trade off one pathology for another pathology. So although it's not in the presentation, it is something that you have to measure the first thing.
And as you can realize, nothing escapes Maz's eyes.
No.
How hard would it be to his resident? Trust me.
Yeah. Well, when you, like for the mitral clips, you routinely measure a valve area.
Absolutely.
No matter how big the valve area it is, because if you tell the proceduralist, we're starting at 7, which is huge, then all of a sudden the amount of clips and the amount of repair you can do goes up, which is fine, right? Because you have more room. But if you're starting like with one of these valves, so I think it was Robert Levine actually who was author on the paper that talked about the diastolic area in these kinds of valves is a lot smaller than we think. So if you're starting at 3 and then you just put a ring in, which probably isn't going to reduce the valve area as much as actually doing repairs and especially alpha areas, but it is going to reduce it some. I think you'd be surprised what the valve area is afterwards, even if the gradients are low. But I'd be interested to see what the valve area was in that patient after.
Yeah.
Excellent. But that would be for the next time. So until next time, thank you very much, Andy. Appreciate it.
Yeah. Thank you.
Thank you very much, Aidan, for presenting this case.